Our next speaker is Steve DeMeester. He's going to discuss the endoscopic treatment of Barrett's.
Good morning. Thank you for this opportunity. I appreciate the chance to talk to you about Barrett's esophagus. These are my disclosures. None of these should pertain to this morning's talk, at least not yet. C2 Therapeutics, perhaps in a year or two, will pertain, but not yet. Barrett's esophagus is an important issue because the incidence of Barrett's esophagus is increasing. And the major issue related to the importance of Barrett's esophagus is its relationship to adenocarcinoma of the esophagus, which, as most of you probably know, is the fastest increasing cancer in America, outpacing its nearest competitors by almost 3 times. Fortunately, we have a screening technique that can identify Barrett's, and once Barrett's patients are identified, they can be in a surveillance program where we can monitor for progression of Barrett's. As a consequence, many centers across the country and around the world are finding an increasing prevalence of early-stage cancers. At USC, about a third of my practice is now early-stage adenocarcinoma, which is good. The traditional therapy for high-grade dysplasia or intramucosal cancer is an esophagectomy. And make no mistake, esophagectomy has some advantages. It's curative in these early lesions in essentially all patients. It's a one-shot therapy. After the esophagectomy, you're pretty much done with your Barrett's and cancer risk. But it comes at a price. There's significant short and long-term morbidity with an esophagectomy, one of which, and not the least of which, is the fact that patients have lifelong reflux, and you can't really correct the reflux in these patients. The alternative then is to preserve the esophagus, and there are now techniques that allow us to do that with endotherapy. Certainly we can reduce the morbidity by preserving the esophagus, but it's not easy. Most of these treatments are multiple and require frequent visits by the patients and several procedures. There's always the potential for residual or recurrent Barrett's or cancer, but on the other side, we can ultimately control the patient's reflux disease, potentially with an anti-reflux operation. So these are the issues I'd like to consider with you briefly this morning. Who are candidates for endotherapy, and what technique or devices should we use? What are the results? And most importantly, are we compromising survival with endotherapy in these patients? Then the issue of should non-dysplastic Barrett's esophagus be ablated, and what do we do after ablation therapy? Well, first and most importantly, who are candidates for endotherapy? The key is to make sure that patients don't have a more than superficially invasive cancer, because we know there's a clear association between the depth of tumor invasion and the risk of lymph node metastases. If the tumor is limited to the mucosa, does not break through the muscularis mucosa, illustrated in the brown layer there, the risk of lymph node metastases is very small, approximately 2%. As soon as the tumor violates that muscularis mucosa and enters the submucosa, the risk of lymph node metastases jumps up significantly, up to at least 25%, and then of course with deeper invasion, most patients will have at least one lymph node metastasis. There's some controversy about what's called the low-risk submucosal invasion. Christian L. and the group in Wiesbaden, Germany have suggested that early submucosal invasion into the first third of the submucosa associated with no lymphovascular invasion and a well-differentiated tumor may be something appropriate to treat endoscopically. They've suggested that the risk of lymph node metastases in these patients is about the same as an intramucosal tumor. Well, we just completed analysis of a number of patients at our center, and we have some concerns about that. We looked at all of our patients with intramucosal or submucosal invasion and found that if you broke the submucosa into thirds, SM1, SM2, and SM3, there really was no significant difference in the risk of lymph node metastases, 21% in the first and 26% in the deepest third of the submucosa. Furthermore, we had 6 patients that had the supposed low-risk submucosal invasion into SM1 with well-differentiated tumor and no lymph and vascular invasion, and one of those 6, or 17%, had a lymph node metastasis. So in our opinion, submucosal invasion is not appropriate for endoscopic therapy. So once we've decided on a patient or considering a patient for endotherapy, it all starts with careful endoscopic evaluation. You have to really look at this Barrett's segment, and we use narrowband imaging and regular white light endoscopy, looking for any lesion or mucosal break or ulceration, because those areas are certainly of concern for malignancy. And importantly, endoscopic ultrasound is not accurate enough in these superficial tumors to determine the true depth of invasion. If you have a little tiny tumor, your endoscopic ultrasound won't reliably determine depth of invasion. Fortunately, we have a technique that allows this, and really the cornerstone of therapy these days for early lesions is endoscopic resection. The traditional or the original technique was the Nui cap. I think most of us move to the multi-band ligator technique now because it's faster and a bit safer perhaps. But this allows you to excise small lesions and have the depth of the tumor pathologically evaluated. When it comes to ablation, probably the largest and most common device used is the radiofrequency device by the Barretts company. They have the Halo 360 or circumferential, the Halo 90, and now the new Halo 90 Ultra. There's also some use of what's called the cryo spray, or freezing instead of burning the Barrett's mucosa, and this has been popularized by CSA Medical with a spray catheter. So what technique do we use? Well, again, it starts out by what your endoscopic evaluation shows you. If you see a small lesion or nodule, then you have to excise that to determine the depth of invasion. If the Barrett's mucosa is flat, there's no lesions or ulcers, then it's a choice of which ablation technique you're most comfortable with. Most of us are using radiofrequency ablation. I've had no experience with cryo yet because their original unit was not Underwriter Lab certified and would not be allowed in our hospital. But the radiofrequency ablation has been around for a while, and most of us are comfortable with that as an ablation technique. It will treat a non-visible adenocarcinoma. We know that in patients with high-grade dysplasia, if you take that esophagus out and look very carefully at it, at least 20 or 30% of those patients will have an intramucosal cancer that you didn't identify with your regular endoscopy. But we know that those are present, and the data would suggest that those are adequately treated with the radiofrequency ablation devices. We have some data. This was published by Nick Shaheen a couple years ago now in New England Journal of Medicine. It's a multi-center, sham-controlled, randomized trial looking at radiofrequency ablation for patients with dysplasia. So they had 64 patients with low-grade dysplasia and 63 with high-grade dysplasia randomized. So 42 in each of the dysplastic groups had radiofrequency, and 22 and 21 in the groups had the sham. Up to 4 ablation sessions were allowed at 0, 2, 4, and 9 months after randomization. And this is the data they showed. Compared to the sham control in both the low-grade and high-grade dysplasia groups, a significant reduction in the risk of, or a significant reduction in intestinal metaplasia and the risk of cancer. And this is what they showed for progression of disease. There was only 1 patient in the radiofrequency group with high-grade dysplasia that progressed to cancer for a rate of 2% compared to 19% that progressed in the sham group with high-grade dysplasia. The data with the cryotherapy has been a little less robust. This is a paper published a couple years ago now in Gastrointestinal Endoscopy. And if you look at the data here, you can see that there was a relatively large number of procedures. This is a group of 26 patients with high-grade dysplasia and 5 with intramucosal cancer. And in each group, there were somewhere around 5 or 6 procedures at mean for the treatment. And any response to treatment was pretty high. In the baseline high-grade dysplasia group, about 90% of patients had some form of response. But if you look a little lower, you'll see the complete response. In this area here, the complete response rate's really relatively low in these patients, down at around 17–20%. Furthermore, there was overall outcome from these patients with high-grade dysplasia going on to cancer, esophagectomy, or death. Almost half of the patients in each group had progression. So another paper published by Nick Shaheen just last year looking at 98 patients with cryospray therapy, 60 of which completed the cryotherapy. The mean length of Barrett's was a little over 5 centimeters. It was quite safe. There were no perforations, and only 3% of patients had a stricture. But you can see that the complete eradication of intestinal metaplasia was relatively low. Only about half the patients had complete eradication of intestinal metaplasia after the therapy. And the problem with that is we know that if you're treating a patient with high-grade dysplasia or intramucosal cancer, if you leave any intestinal metaplasia behind, they're at very high risk of metachronous tumor development. So that really is not a satisfactory response rate for intestinal metaplasia. So an important issue then is survival compromised with endotherapy? And we looked at this ourselves in a retrospective study of all of our patients with high-grade dysplasia intramucosal cancer starting from 2001 when we began our endotherapy program at USC. We had endoscopic therapy in 40 patients with a mean follow-up now of 17 months and esophagectomy in 61 patients with a median follow-up a little bit longer of 34 months, and this was just published this year. In the endotherapy group of 40 patients, there was a median of 3 procedures in each patient with a max of 8 in one patient. Most of these, as you can see, were endoscopic resections, 102 endoscopic resections and 79 ablations. The median number of sessions necessary to eradicate all the intestinal metaplasia was significantly fewer in short versus long segment Barrett's. That's not a big surprise, I think. The median time to eradicate all intestinal metaplasia was about 20 months, so you can see this takes some time. There were no complications and outpatient procedure in all. The esophagectomy group was 61 patients, the majority of which had non-block resection or a transhiatal resection. There was also some vagal sparing and laparoscopic procedures in there as well. A staging endoscopic resection had been done in about a third of the patients to make sure a visible lesion was not into the submucosa. One patient with high-grade dysplasia pre-op was found to have intramucosal cancer on final pathology. In 48 patients with intramucosal cancer, there were over 900 lymph nodes removed, and again, only one patient had a positive node for that 2% rate that I showed you earlier for intramucosal disease. There was no mortality, but minor complications occurred in 26% and major in 13%, for a total of about 39%, significantly more than in the endotherapy group. But importantly, there was no difference in survival. We compared overall and cancer-related survival, and as you can see, it's excellent in these patients with early-stage disease and was not compromised by endotherapy. So this is a typical appearance of a patient that had long segment Barrett's that's been ablated with radiofrequency, and you can see there's some little patches of residual columnar mucosa, and it's important to go back and get rid of all of that intestinal metaplasia. Because what we found was that newer metachronous cancers developed in 20% of patients while undergoing therapy before we were able to eradicate all of the intestinal metaplasia. Once we got rid of all the intestinal metaplasia, nobody progressed to cancer. What that means, though, is that 26% of patients that started with only high-grade dysplasia ended up with a focus of adenocarcinoma resected at some point in their course of endotherapy. 20% of these patients have now gone on to have a laparoscopic Nissen for control of their reflux disease long term. This is now that brings us to the issue of should we ablate non-dysplastic Barrett's esophagus, and this is a paper published a couple of years ago, the original AIM-2 study looking at radiofrequency ablation for non-dysplastic Barrett's. And then recently they've reported the 5-year data from that AIM-2 trial. So the original AIM-2 trial started with 70 patients aged 18 to 75, and they excluded patients with dysplasia, esophagitis, or long segment Barrett's esophagus. From that group in the 5-year follow-up study, they took a large number of biopsies. 8% of the patients, 4 of them, had intestinal metaplasia at 5 years. There was one patient that had an off-protocol ablation in between the 2.5 and 5-year mark, for a total of 5 patients then that at some point had intestinal metaplasia at the end of the AIM-2 trial and then on the follow-up at 5 years. All 4 of the patients that at 5 years had intestinal metaplasia were successfully ablated again with radiofrequency and had resolution of IM on biopsies 2 months later. There was no buried Barrett's and no strictures in these patients. So if you look at the best and worst case scenario in this, 70 patients started the AIM-2 trial, 60 were eligible for the long-term follow-up, 50 of them agreed to be reevaluated at 5 years. 5 of the 50 were reablated for recurrent IM at some point in the time frame. So the best and worst case suggests that up to 7% at the low end and up to 36% of patients will have recurrent intestinal metaplasia after ablation long-term. So it raises the question, what failure rate is really acceptable when we're treating non-dysplastic Barrett's? Or is any failure acceptable? If it's not 100% long-term cure of intestinal metaplasia, everyone still needs surveillance because you can't pick out the patients that might still have intestinal metaplasia, and so therefore you can't exclude surveillance from anybody. And the reduced cancer risk remains unknown in these patients. After endotherapy, my approach is a repeat upper endoscopy in 8 weeks. If there's any residual intestinal metaplasia on biopsies, they go immediately back for another ablation procedure until all of the intestinal metaplasia is gone. Once the intestinal metaplasia is cleared, I follow them with EGDs for every 3 months, for a year, and then annually. And again, fundoplication is the preferred therapy for long-term reflux control. So in conclusion, endotherapy with a combination of endoscopic resection and ablation has really revolutionized the treatment of high-grade dysplasia and intramucosal cancer. Compared to esophagectomy, endotherapy is associated with a similar survival, but significantly fewer complications. It does, though, require more procedures and intensive follow-up. Endotherapy must be aggressive until all the intestinal metaplasia is gone to reduce the risk of metachronous tumor development. Ablation of non-dysplastic Barrett's cannot assure that no intestinal metaplasia will recur long-term, and thus the value of ablating non-dysplastic Barrett's remains unclear and will require further evaluation. Thank you.